Yeah, I call the next speaker Dr. Arvind Kulkarni to speak on prevention of junction failures. Arvind, you muted.
Dear friends and colleagues, I thank you for this invitation. I'm really humbled. This is a very interesting topic. There is no doubt in my mind to say that this is one of the greatest challenges that even the most expert of spine surgeons can face, that is junctional problem. This can be classified into proximal junctional kyphosis and proximal junctional failure. These are two different entities but are generally used interchangeably, which should not happen because junctional kyphosis is a very common situation and it can go unrecognized and can remain asymptomatic. It basically means that there is at least 10 degree of kyphosis between upper instrumented vertebra and upper instrumented vertebra plus 2. While proximal junctional failure, as defined by International Spine Study Group, basically means that this particular condition is symptomatic and would present in various ways. It could be a fracture of the upper instrumented vertebra or the level above. It could mean implant failure at the level of the upper instrumented vertebra. It could mean PJK, which is proximal junctional kyphosis, which is more than 15 degrees and symptomatic at the upper level, or the need for extension of fusion within 6 months of primary surgery. How common is the problem? Quite common. The prevalence of PJK is close to 20 to 39%. The prevalence of PJF is about 1.4 to 35%. And lower thoracic and thoracolumbar region is the most common level of getting a PJK because most of our instrument, long lumbar instrumentations stop there. And, because you're going beyond the apex of thoracic kyphosis, upper thoracic level, upper thoracic region is has a lower prevalence of PJK and PJF. When does this disastrous complication occur? It usually occurs in the first 3 months, and by 18 months, 80% of these patients would have presented to a clinic with this particular complication. Now, every condition needs a classification for us to have a uniform language. So this particular classification is basically a morphological classification. It's simple and easy to apply. It basically defines the morphology of the injury, whether it is a ligamentous failure, whether it is a bony failure, whether it is a failure at the implant and bone interface, and also the degree of junctional kyphosis at that particular level, and whether if this particular situation is associated with spondylolisthesis or not. On one hand, it describes the morphology of the complication, but it lacks prognostic information and does not guide management. It does not provide any information regarding natural course, severity of the disease, neurological involvement, and the need for management. Whereas this particular classification, it's basically a PJK severity scale. It scales the degree of severity by accounting into factors such as neurological deficit, focal pain, instrumentation related problem, change in kyphosis, that is PLC integrity, the fracture of the upper instrumented level and the level above, and the level of the UIV. So there is a strong correlation with health related quality of life outcome scores with this particular severity scale. And it also has a strong correlation with indication for revision surgery, a score of 7 or more indicating revision surgery. So what are the risk factors to get a PJK? One of the most important reasons and one of the most common causes is careless handling of soft tissues, injury to the facet capsule, injury to the posterior tension band, that is the interspinous and supraspinous ligaments, and the posterior musculature, thoracolumbar fascia, etc. Inadvertent injury to the levels above can cause PJK on day one, can sow the seeds for a PJK on day one of surgery. The next common cause is having a stiff construct lower down, which could be a anterior posterior fusion, use of pedicle screw constructs, use of stiff rods, usually using alloy of cobalt chromium or using multiple rods. The next common cause would be, fusion to sacrum. This will abolish all the scope for compensatory mechanisms, and that can stress the junction level and lead to PJK. Again, magnitude of correction. If there is an aggressive correction, over-exaggerated correction, especially in elderly people, this can cause increased stress at the junction level and cause PJK. High BMI is obviously an important cause of PJK. And again, osteoporosis, which can lead to implant loosening, fractures at the junction levels, is an important cause of PJK. Now, this is an example of a patient who was fused using a pedicle screw construct, and over a period of time, patient developed pain at the junctional level, and there was no clue as to what was happening. A flexion extension X-ray and CT showed that there was a junctional problem, and this patient needed an extension to a level above. Again, another patient who had instability and stenosis at L4-5 and L5-S1 was fused, and after 5 years, she came with a junctional problem higher up. So a stiff construct is one of the common causes to lead to a PJK and PJ. What are the modes of failure? So how does this present? It either presents as fractures. This is most commonly seen at the most common region, that is thoracolumbar or lower thoracic region, that is a fracture. And at the upper thoracic region, it usually presents as a soft tissue disruption, as a failure of the posterior tension band. Now comes the million-dollar question: how do you prevent this unhappy complication? What is the key to prevent this particular disastrous complication? So there is no one key. There are several keys which need to be used. There are several strategies in combination which need to be used to prevent this particular deadly complication. So, soft tissue considerations. So what you do is you localize your upper instrumented vertebral level using fluoroscopy, and be as accurate as possible to avoid any inadvertent overexposure and unnecessary soft tissue damage. Okay, and pay tissue respect. You preserve the interspinous and supraspinous ligaments, supraadjacent facets, and their capsule at the upper end of the instrumentation construct. Next is hard tissue considerations. That is in relation to the bone. So most of the patients that we operate on are elderly patients. They're mostly women, and they have a combination of senile and postmenopausal osteoporosis. And osteoporosis significantly contributes to junctional kyphosis. And we have seen that DEXA undermines osteoporosis because of various reasons. And QCT is something that we prefer to get the right idea of patient's bone density. So it's very important that this particular condition is treated preoperatively or perioperatively to prevent fractures at the upper instrumented level or above. Second is avoidance of implant preloading at upper instrumented level. See to it that your rod is contoured well, and it is not made pushed. You don't need rockers, you don't need persuaders, you don't need reducers to put this particular rod and fix INI on top of it. The contouring of the rod should be absolutely perfect, otherwise it will stress the upper level. Again, it's been advised to use cement at the upper instrumented level and the levels above to gradually change the stress at the junctional level. This is a good idea, but has mixed outcomes, because fractures occur above the cemented level and can lead sometimes to accelerated ASD, that is adjacent segment disc degeneration, due to interference with the disc nutrition, because the disc nutrition comes from the vertebral bodies. So it has mixed outcomes, but this is something that has been suggested for long. Again, this is very, very critical. Where would you stop your upper instrumentation? So there's no level which is immune to PJF. This is a golden dictum. It is said that a level above T8, that is upwards of thoracic kyphosis, has a lower risk of PJK. So extending the instrumentation up to upper thoracic levels makes sense and is desirable. But as mentioned before, no level is immune. Only thing is the incidence and prevalence of PJK is lower at upper thoracic level compared to the lower thoracic or thoracolumbar levels. What is important is that the level which you choose has to be neutral and stable. Again, selecting your lower instrumented level is also very important. All efforts must be made to avoid fusion to sacrum or pelvis, if possible. So this patient was advised a fusion all the way to the pelvis because patient had scoliosis along with L5S1 lytic-listhesis. He was a young lad. So we managed to save this patient from being fused all the way to the sacrum and left 4 mobile levels intact by doing a judicious fusion from upper thoracic to L2. So this is a young patient and we saved mobility at 4 particular levels. So this is the way one should think out of the box and save fusions all the way to the sacrum or pelvis. But as and when, if it is necessary, one should not shy away from stopping short of the sacrum or pelvis. Whenever necessary, you have to go to the pelvis. Whenever in doubt, you have to go to the pelvis because there is a high complication rate at the lumbosacral junction when L5 or S1 was selected as LIV. This is usually in adult deformities. And the lumbosacral complication is lowest when you use iliac screws, and you also get better sagittal alignment when you're fixed to the ilium. So on one hand, you should avoid fusion to the pelvis, but whenever it is necessary and whenever it is indicated, you should not shy away from stopping short of pelvis. Otherwise, you can have junctional distal failures as shown here. You can see the vacuum phenomena at L5S1. So we had to go all the way to S1 and do a L5S1 fusion later on. Or this particular adult deformity, which had failed, decompression fusion, wherein we had to go to pelvis because the patient had a breakdown at L5S. Again, selection of appropriate implanted upper instrumented vertebra. So it is suggested that hooks are better than pedicle screws in preventing PJ. So this is a patient who was operated by me about 14 years back for scoliosis. You can see there's hardly any junctional kyphosis because there's no midline dissection to put these hooks. These are transverse process hooks. So this is a very important concept we should understand. The pelvic parameters, the sagittal balance parameters of a 30-year-old are different from an 80-year-old. So trying to get a correction with parameters of a 30-year-old in an 80-year-old will lead to disastrous complications, and that can definitely lead to PJK. So it's very important to contour your rods, achieve a correction that is relevant to that particular age group. So this is one of the common causes for getting a PJK. Again, to recreate the posterior tension band, some authors have suggested using Marcelin tapes that are drilled into the spinous process on the levels above and connected to the spinous process at the levels below to kind of pull the spinal column posteriorly and maintain the tension band and prevent decay. Again, using a surrogate fixation far laterally on the ribs using connectors and Webster device has been suggested as one way of preventing PK, but it looks quite elaborate again and appears like another surgery in itself. This is an intelligent way of avoiding PJK. You don't expose on one side, so maintain all your soft tissue envelope on one side and just put hooks on the opposite side. So we know the hooks are associated with lower incidence of PJK. So on one side you apply hooks and on the other side you preserve the soft tissue, and that is postulated to prevent PJKs. So PJK and PJF remains an unsolved problem. There is no perfect solution. we need to use a combination of various strategies. It is very important that since it is inevitable that we should counsel patients about its existence and prevalence, we need quite an amount of research in preventing this particular disastrous complication and also find a cure. And one way of preventing is operate less, and if at all you need to operate, then fuse less. Thank you.
Thank you. Thank you. Arvind, it's very nice. A very nice talk. Thank you. Thank you very much, Arvind.